right, welcome to Rxperience. My name's Chad Wers. I'm your host alongside my co-host Tom. Tom, welcome back.
Yes, glad to be here. Exciting new year.
Today we have a very special guest, Jason Costa from Horizon Pharmacy. We were just talking off air. Jason is not a pharmacist, so we're going to have him explain his non-pharmacist origin story. We usually have our guests give their pharmacist origin story if they're pharmacists, of course. But you operate a long-term care pharmacy in Rhode Island, and
correct.
Tell us about yourself. Tell us about your pharmacy.
Sure, happy to do so. My name is Jason Dana Costa, and my technical background is in accounting and finance, with a strong background in marketing and management. How I sort of fell into that was, believe it or not, I painted a kitchen and lifted the can of paint. And back then, jobs were advertised on the things called newspapers. So when I lifted up the can, underneath there was this advertisement for this thing called this coordinator of accounting and finance, which, having an accounting background, I was like, ooh, I think I could do that job. And it turns out I did. I interviewed for it, and I actually went to the Christmas party before I'd worked the first day of work for a place called New Bedford Whaling Museum in New Bedford, Massachusetts. I'm originally from Massachusetts. I work in Rhode Island now. And I spent 30 years working for a lot of different nonprofits, some in youth intervention, some in architectural history, whaling, given that I mentioned the Whaling Museum. But eventually I pivoted to healthcare, working in a type 1 diabetes research organization. And then most recently, before I came here to this long-term care pharmacy, I was the CFO and COO for a community behavioral health center here in Rhode Island called Newport Mental Health. And that is kind of where Horizon Pharmacy was birthed. We're a little over 11 years old now, and we are what I would call a social enterprise. We are owned by what was 4 community mental health centers, now 3, 2 of them merged together. And there was a pharmacist who was helping Newport Mental Health, and he had reached that point in time as an independent pharmacist that he wanted to retire. And CVS was happy to buy his regular retail component, but wasn't really interested in the LTC component. So this individual, Mr. Wally, was very gracious as a parting gift and a donation to Newport Mental Health, provided his expertise and helped us stand up what is a limited liability corporation across these, what again was 4 community mental health centers, to have enough scale, for lack of a better phrase, to be able to provide LTC pharmacy services to their community mental health centers, which at the time was around 700 or 800 patients, thereabouts, just like you would expect a packaged medication system to be. But what makes us really, really kind of neat is we service the entire state of Rhode Island. And because we were owned by those community mental health centers, the profit we get goes back to those organizations and actually subsidizes around 1,000 patients to get free behavioral health or subsidized behavioral health and substance use. And that's a lot of people, 1,000 people. So imagine somebody who's unhoused. Very often they don't have insurance. These community mental health centers are able to provide services because of the profit generated by this agency. Or even somebody who does have a job and has a commercial insurance. It's very typical for somebody to be paid for by the insurance to see their therapist, to get their prescriber and medication. But let's say maybe you're a recovering alcoholic, and really what you need is peer support. That sort of case management services or vocational support because you're in a career transition and kind of getting back into the workforce. Having somebody who's an employment specialist, those things aren't typically covered by your commercial insurance that you would have. The existence of Horizon Pharmacy make sure that these people get the care that they need and succeed. And it's grown now. It's like I said, we're almost 12 years old. And at this point, we're around 1,600 patients at any throw a dartboard on the wall day of the year. And maybe in reality, given the rotation coming through substance use, which is a significant part of our work, people are there for 21 days, 28 days, sometimes multiple times a year. We'll probably see about 25 to 2,600 individual people during the year. So it's kind of a unique organization. And how did I end up here? the inaugural CEO of the pharmacy that started it way back when. He retired about just shy of 3 years ago. And I, being the CFO, sort of quasi CFO for the pharmacy, I saw opportunity, as I was talking offline to Tom before we started recording. I saw ample opportunity to make the organization more efficient. I'm kind of an intellectually curious guy. And I didn't know a lot about pharmacy, so I wanted to learn, and I leaned in. And thanks to the couple of pharmacists, our pick here and our VP of compliance and strategy, they're willing to put up with what I call the Mickey the Dunce questions. I put the dunce cap on and I ask a question like, why do we do it like that? And they answer. So it's been a blessing.
Really cool. I mean, I always think it's interesting when somebody from outside takes that curious look at an operation in a business. I'm actually more interested, being an accounting finance person, how you looked at the pharmacy and saw opportunity, because I think if you asked all of our pharmacists, they'd be like, it's such a struggle to run a pharmacy. The margins are tight. It's difficult. So to see people on the other side, the accounting side, see opportunity makes me feel like, there's hope in pharmacy. That pharmacy can be operated at a way that does provide benefit, whether that benefit is pouring resources back into a nonprofit or not. Just the idea that someone from outside said, this is a good business. I want to be part of that, or I think I can improve that.
Yeah, I absolutely feel very strongly we have improved it. Pharmacy, generally speaking, there's a lot of detail and workflow situations, and thankfully there's lots of automation out there, the physical automation systems that I knew could be leveraged even more. I'm not a technologically fearful person. I'm very happy to use technology. And, ultimately speaking, accounting is essentially the oldest information system there ever was. There was an abacus in China,
Right.
And that's tens of thousands of years ago, whatever it might be. It's just an information system. And, all you really need to do is utilize that to ask questions. It's never really an answer. You always just want to keep yourself asking questions. Can this be done more efficiently, more effectively? Is there something that you can do better? Because ultimately it comes down to people, and everybody likes to do something that they're interested in. So I'm always very interested in, what a person's personal growth means, because I'm very happy to have a person grow within my organization, but also outgrow my organization. I don't mind being grown through, because there are many people that enter pharmacy that are pharmacists, and you've clearly made a commitment to this career. It's a lot of schooling. Many of these people are doctors, and that's a lifelong commitment. But the other half of the business model here is a lot of people are really high school graduates, and this is a waypoint, and really they might be in college and doing this as a job for a little while, or they're a working mom, or something to that effect. So you got to find what that incentive is for that person, and where they want to see their career grow, and then help them work to the highest scope of their service to get them interested. I'll give you a silly example, but I want everybody to be a Tech 2 here, and you're not always going to enter being a Tech 2, you're going to enter being a Tech 1. But we have at I instituted when I got here, a very clear growth pattern for people to join the organization, learn our automation, graduate to being a Tech 2. I will fund their Tech 2 study materials. I will absolutely give them a very clear, I say it upon hiring, we are going to give you another $1.50. You go get your Tech 2. Go get it. You'll make more money. Go get it. I'll be able to use you at a higher level, and we'll fund doing that. And we partner with the state of Rhode Island to do so. They have workforce development dollars. It's not like it's all coming out of my pocket to be able to get people to do what they're most interested in, or take even the automation of the pouch packaging system I was telling Tom about initially. That's sort of the difference between a pharmacist checking a bubble pack, we use medication on time, versus, where you're looking at every single pill and, and inspecting it. It sounds silly, but buying people magnifying glasses that have a light for them to look at, the pharmacist thought I had given them the lottery ticket. but even more so, getting a pouch packaging system where they're now managing by exception, like something's wrong with that one pouch,
Right.
versus looking at every single one, you know, helps them not get exhausted with the job and then do things that are far more interesting, like MTM work or partnering with our facilities. Because I'd much rather have the pharmacist going out and visiting the facilities that we work and working with the medical team and the nursing team on real case conferencing. You know, being a behavioral health pharmacy, which is predominantly what we are, about 80% of behavioral health and substance use, these are the kinds of people that are not like an assisted living and, 28-day cycle refill, constantly doing it. We're talking about med changes every 2 weeks sometimes, frequent hospitalizations, so having somebody with the skill of a PharmD integrated into our community mental health systems helps get people better.
Yeah.
But looking at the stamp on the back of the pill doesn't give them enough time to do that.
Right.
So I really think it's recognizing, what people, particularly in this case, pharmacists I'm talking about, why they enter the field. They want to help people. So let's get them in the places and spaces that do that. Yes, we all have busy work. I'm an accountant. Do I really feel like balancing a checkbook again next month? No. I'd much rather do this strategy of where the organization's going, but hey, we all have the route work to do, but how do I do it faster, better, cleaner, safer? Anyway,
Awesome.
I kind of tangent in there, but hopefully I was answering your
great.
thought why I got interested.
Yeah. And I tell you, being kind of in the trenches, being like Chad and I, we've been in long-term care, pharmacy operations and consulting for, our entire careers. And it was is very transactional. Based. I didn't quite know what you meant by social enterprise until you did explain a little bit deeper. And, it's so refreshing to hear that, your focus is really about integrating people, common people, everyday person back into society, regardless of their background with drugs or alcohol or, they're unhoused or whatever led to that situation. And most of it is, mental health, challenges, but utilizing a tool like pharmacy and like behavioral health to be able to incorporate them successfully back into society. And then be focusing on the technicians, the people that really kind of make our lives possible. As pharmacists, we almost kind of take for granted at times, the technician work, but the career path, the true career path for technicians is, I'd say, is lost a lot in long-term care pharmacy and retail pharmacy. We don't take the time. We're trying to survive. We're trying to survive lower reimbursement. We're trying to survive growth and expected demands from our customers. But to invest back into the technicians that really are the oil that makes our engine go is very, very impressive.
Yeah, I tell you, any state who might be hearing this later, get connected with your workforce development people in the state or your local chamber of commerces. We were able to launch a great program that's actually coming to an end in about 30 days. I got an email earlier today saying, hey, your grant's over. We had a threefold thing that grant did. We trained every single staff member we had in mental health first aid training. So every staff member here got some level of empathy of what it is to work directly with the clients. Because long-term care, you kind of have that barrier between you and the actual end customer. It's a B2B business rather than a B2C business. So I really wanted to make sure the staff garnered some empathy about what's happening on the other end. That was number one. So, and it's good. I mean, you can take adult mental health first aid training. You can take kids. Lots of these are working moms. Of course, they'd love to learn a little bit about the signs and things their kids may need. So we funded that, great. And the thing did this. Second, it also allowed us to fund certifications for the pharmacists. So there's many pharmacists that want to become board certified, but $700 worth of study materials. And, oh, by the way, the test is another $700. I said, great, with this grant, I will fund you doing that. And I got about 50% of our 8 staff, pharmacist staff, to be interested to do so because we're investing in them. And of course, I said, I would love you to become board certified in behavioral health. That's what our skills are. But don't worry, there's comorbidities here. If diabetes is your shtick, I'm not going to tell you what to study for. What I'll tell you is I'll pay for the test. and with the state, we were able to do that. So that those are reoccurring dollars that typically exist out there with the Chamber of Commerce and the states. And Jason's not making anything up, but many people, I'm assuming in my chair, are so busy doing the work and getting the pills out, you don't remember that these other opportunities are there to avail themselves to you. And a little bit of investment now just gets your staff engaged and relieves some level of work for you, 6, 8 months down the road.
Yeah, I think that's a real key, is because you look at it differently, because you come from a different discipline than maybe some of the pharmacists that run long-term care pharmacies. You're more familiar with that kind of thing than they are. To your point, they're working on getting the pharmacy work done. This is what I went to school for. This is what I know how to do. I'm going to run this business like a pharmacist. And you might not just be aware of those workforce development grants and things that people that work in finance and accounting might have been familiar with in another experience and know how to go get and apply to their business. I think that's really cool.
Yeah.
Tell us a little bit about you talked about B2B, B2C. What does the pharmacy do? You have a special population that you're taking care of. What do the pharmacists do beyond, getting the packets out and getting the pharmacy piece out? What else are they doing?
Well, I may have what you mean by pharmacy piece wrong, but I'll give you some of the ways that we interact beyond just getting the pills out the door, the bill and fill. So we definitely do case conferencing for every one of the medical directors in the facilities that we are in. So there is a standing meeting, depending on their need. Some are once a month, where we're specifically getting together with the medical director or the key prescriber to talk about a problematic person, whatever that may be. And that's formal. So call it non-emergency need that we're able to do that. And we can kind of plan for it. Say, Sally, it's the third time she's gone through the ASU, which is our emergency door for substance use, and gone to one of the 5 substance use 28-day bed things. Then we have quarterly meetings with every facility, period, that we just get engaged with, talk to them, find out where their pain points are, make sure that we're coordinating with them to make services and delivery. And by the way, I'm doing a pharmacist with doing that, because oftentimes I am with the director of nursing, and I'm not a clinical person. So, there's conversations that go right over Jay's head, that I just don't know what the right thing to do is. But getting my pick there once a quarter, and we service about 150 locations within the state of Rhode Island, but maybe about 22 to 25 businesses, with one key nursing team. So we go there and do that work. And a lot of that turns into what looks like a lot of MTM type of work. So literally talking about specific clients and needs. Then, of course, we do vaccinations for each one of these facilities. Not a huge revenue generator for us. I know some pharmacies really specialize in that. We consider it an ad hoc service. If you want us to do it, great, we'll coordinate it. I'm not making tons of bank on it, but it's a business, and it's good business to do that. And then for my own part, what I'm trying to really pivot our pharmacist team to really begin to start doing is to really begin to start doing LTC at home type of work, which is right now, because it is a B2B, that sort of final mile delivery of the medication is really on the nurse manager, residential case manager. We deliver the meds, they sign off on it, it's yours, you have your thing. And one really big pivot that I did, because I read the LTC at home regulations, when I first got here, people would graduate from these programs, and part of the reason why they were covered was packaged medication. It sounds silly. Well, maybe it doesn't sound silly. The first thing you learn is your colors. You know what yellow, blue, red, green means, and you can identify it. A lot of people with substance use and behavioral health, their brains are having a challenge. And our system that we use, Medication on Time, is a color-coded system. So yellow means morning. Open the bubble that is yellow first. At nighttime, it is blue. Open that one at night. And what would happen is people would get well and graduate, and my predecessor would, okay, you're no longer part of the facility. We're not going to deliver the meds to you. And all that was just happening is people would then hit the hospital 6 weeks later. I said, we're done with that. if you're a Horizon Pharmacy patient, you're going to graduate. You're going to stay with us minimally 6 months because the regulations minimally allow that. Because if you are at a facility 6 months later, you can say an LTC. And I said, as far as I'm concerned, pardon me for recording this, and I might get in trouble. Come catch me.
Yeah.
These people need to be well. Packaged medication helps them be well. I'm saving the state a ton of money by not having them hit the emergency room again. Right now we probably have 25 people we're doing home delivery for that graduated from somewhere, and they're staying well because of what we do. So there is some extra monitoring that the pharmacists are doing now because there is that direct interaction of LTC at home. And for lack of a better phrase, we are the immediate caregiver, the person that's sort of qualifying them into that program that they wouldn't otherwise be doing. And quite honestly, I see that as the future. I don't know if either of you know what LTSS is, long-term service and supports. There's 2 or 3 providers here in this state that have thousands of people doing that. And I want to integrate with them and put this is Jason, this is future thinking. Okay, so we're not doing this now. So
Sure.
asterisks everywhere. But I want to actually get our techs to be interested in becoming community health workers.
Yep.
It's about a 600 to 1,000 hour qualification. Again, growing their professional skills while still being with me, and bill for them to go fill out some of the paperwork for LTC at home and these people under LTSS services, because I'll get a little bit of money, but at least we can pitch the packaged medication and get particularly some of these older adults that are coming into dementia and cognitive issues to support the work. And I personally envision that that's going to be really led out by a different, I can call it like assistant pick, somebody who's really managing that part of our work. Hey, did I answer your question?
Yeah, absolutely.
Yeah, I mean, Jason, you're spot on. For years, just to go back a little bit on the long-term care pharmacy history with long-term care facilities, we for most of our industry, people would go to the nursing home, they would discharge, they'd be back in the hospital in 6-8 weeks, and because they didn't have a good transition, especially with their medications. And so we've had a big push, CMS laws and a few things change with at risk and analyzing the nursing homes for rehospitalizations. And so the pharmacies try to come along board there and help that transition. But a lot of long-term care pharmacies, stable, good long-term care pharmacies, just didn't feel the organization was set up to properly care for people at home. And now here recently with long-term care at home conversations and discharge to home programs, more and more long-term care pharmacies are doing that and trying to fill around and kind of get into that. But certainly when it comes to something like mental health, outside of group homes, institutionalized, stable group homes, most long-term care pharmacies aren't really getting into that mental health segment of that space. And you could probably give me a lot more stats than I can give you, but I know in general, mental health is a problem that's growing rapidly in the United States. Same way
Absolutely.
with, alcohol abuse and drug abuse. And yet there is no, there's not enough governmental programs in place to help them transition off the street and then into working society. Now, for long-term care pharmacies, I appreciate you mentioning non-for-profit because we all feel like we're non-for-profit at one point or another because of the reimbursements getting hit. But my question is, if I'm a long-term care pharmacy and I see this podcast and I say, you know what, I've got a large at-home mental health or unhoused mental health issue, and I would like to get out there and start growing my long-term care pharmacies because I've got the packaging, I've got the delivery, I've got all the blocks that I need to make this happen. What would you advise for those pharmacies to start? Here's what you need to do to kind of set this at-home mental health system up in place.
Get a hold of your FQHCs and your community mental health centers. The FQHCs will be a little bit harder, of course, because they're going to want that 340B relationship type thing. So of the two, if you're really green with it, I would definitely go with your community mental health centers because they're going to be a little bit more hyper-focused in this area. And frankly, because of this administration, the FQHCs are a bit under attack around the 340B. So they're going to be looking at that kind of relationship in a little bit different way. I would also get a little educated on some of your substance use providers that are out there, and a lot of them are for profit, so they're in it for the same reason you are, and they know who these people are that are coming around and round and round. When I first started here, we were only doing business with the ASU, which was sort of the, for lack of a better phrase, the non-hospital temporary stay, 23-hour bed sort of moment. So just before you really kind of hit off all the hospitalization costs, who essentially were a warm transition to several of the substance use 21 or 28-day providers. I intentionally started going towards each one of those other providers because people don't hit recovery round one. They sometimes hit round five,
Right.
and the fact that our pharmacy knows these clients and where they're boomeranging around, we became a valuable resource to several of these guys because, prescriber A was like, I want to try this thing. Well, actually, we tried that 2 things ago. Here's the reactions. Here's why it didn't work. That's value added to that prescriber. Even if they still want to try the therapy again for some pivotal reason that may have changed, at least they've got the information, which normally wouldn't have been available to them. The second thing that was a really costly thing that I did, but hospitalizations are a huge bugaboo to everybody because the hospital, once they're in there, A, it's expensive, and B, there's a very challenging process in discharging people. Essentially you got somebody's in the hospital. Actually, I should say, if you know somebody's in the hospital, you know why I'm saying that in a minute. You got about 2 hours between when the doctor discharges them and when you got to have the meds ready. And it's complex because these people are sometimes on 15 meds. So it was super costly. I realized not every pharmacist could do this, but again, talking to your local providers, you might do what I did here. There's this thing called Current Connect in the state of Rhode Island, which is essentially software on the back end that Medicaid and Medicare can see every hospitalization and every patient in the entire state. And what we would often be troubled with is we would find out about a hospitalization sort of after the fact. And if you guys are LTC pharmacists, you're billing and filling 10 days before somebody needs the meds, and 6 days before their meds hit, suddenly in the hospital, you're kind of waiting. What's going to happen? And sometimes we're waiting ignorantly. We had no idea somebody was in the hospital. Getting connected to Current Care gave my pharmacist, particularly my VP of Compliance and Strategy, direct insight when we knew somebody was hitting the hospital. Sometimes we were telling the nurses of the facility, hey, Sally hit the hospital. Did you know that? Oh, okay. So now we're ready for those kind of transitions, and it's less um, it's less like getting hit with a baseball and all you heard was a crack and you turned around, there it's coming at you. It's not that kind of thing. We know it's happening. It gets the team prepared a little bit more. And what I was able to do initially is I was willing to take the cost, but I did the same thing I'm speaking to you to the state and saying, do you really want to charge me $45,000 a year for this little tiny LLC to get insight on what's going to help you anyway?
Right.
And they significantly discounted the cost for me to do that because the insight mattered that much, particularly to the Medicaid rolls here, which is, again, about 80% of my business. So it was actively getting engaged. Going back to your initial question, how does somebody get engaged in this? Talk to your community mental health centers. Talk to your Medicaid representatives. They know where the pain points are in the state. Of course, there are bigger states than others. But for me, anyway, in this place, having those relationships, knowing that I was a trusted person coming from the community mental health centers to begin with, it opened some doors for me and got people to hear how I know we could reduce the current cost of care. And I'll give you one other odd little bullet that I did too. The ACOs, if they survive what the market's doing these days, so that's a big if. But I was involved with a couple of the ACOs, and I really got some claims data and proved that this package medication system that we were doing in this particular pharmacy was better than any other pharmacy. We were something like 30 to 40% better at hospital diversion than any other pharmacy in the state.
Wow.
And I held that up at the Medicaid guy and went, tell me that's wrong. That's 25,000 claims.
Right.
Right.
Data helps people. These people it all comes down to reducing their costs. And if you can find ways to show you're efficient, you can do things that are going to save them money, they're at least going to listen to you. Whether they'll change or not, who knows? It really takes the politics of all that. But at least in our case, 3.5 years on, knock on wood, somewhere, it seems to be working here, and it's allowing us to grow. Did I answer your question?
Yeah. No, no, for sure. I mean, you're preaching to the choir. Adherence packaging, I believe, is the best type of packaging for institutional and at home. But especially if you start getting up to 8, 10 meds, there's just no way, for people to dive into vials or have 10 unit dose cards and punch them out and feel like they're going to get every pill at every administration time successfully. And then you have a high acute patient that medications change often. Well, that cycle needs to change, and now all of a sudden you have cabinets full of half-eaten medications, that are sitting there in vials that they get confused. And that cycle fill adherence packaging, I'm part of the choir there for that, for sure.
I think, I always think of things in these, circles of what our members do, what the pharmacies do with respect to long-term care and where the overlap is. And I think what you're doing is so unique in behavioral health, mental health, substance abuse. And there's so many common things, and then there's so many things we can learn, some of the pharmacies can learn from what you're doing. Particularly as we kind of all, divert our attention to this at-home population where the patient's medically complex, where, we don't have as many places for older adults in nursing homes. Not everybody can afford an assisted living, but they need the support services around the medications so that they can stay well at home.
Mm-hmm.
And there's some complexity there. It's not a nursing home where the nurse is going to pass a med and that they got it every day. It's a house with, to Tom's point, all kinds of things in the cabinet than just the meds, old meds. If you've got a system and some wraparound services that can help that person take their meds correctly and stay on their meds correctly, they're going to stay out of the hospital. And you've been doing that. Your data shows that. And I think that's awesome. And certainly something that I think is interesting to other pharmacies that might not be doing the exact same thing as you, but doing something sort of like you with those at-home patients. What have you learned? How do you handle your patients? What insights do you have that maybe they don't, and probably vice versa? What insights do they have that maybe you haven't seen because you're not dealing with that same population of people? It's interesting.
The other thing that I probably worth mentioning, and I'll plug for a moment. I'm assuming you gentlemen know Rx Insiders and the 20 Ways thing. I was, interestingly enough, my VP of Compliance Strategy, she's on the cover of the most recent one with a great story about her personal work with FEMA. But the preceding one, I did an article about what are called CCBHCs. So that would be like September-ish, I think, which are called Certified Community Behavioral Health Centers. It's SAMHSA's answer to FQHCs, federally qualified health centers. I wrote a brief article in there. Who knows if CCBHC will survive under this regime and things that they're doing to HHS and SAMHSA. But just being even familiar with CCBHC's programs and work could be very helpful to a long-term care pharmacy that's working with this type of population, because there's these 9 key services that each one of these CCBHCs should do. And it's sort of the gold standard or, good housekeeping seal of approval. If you're going to do really well by these types of patients, these are the kind of programs you need to have available to you. Even just having that familiarity of what those programs would do, or even the thing I mentioned earlier, just training my staff in mental health first aid, that sort of awareness really changes things. I can tell you unequivocally how my techs treated the clients who were coming in before and after we had that mental health first aid training was noticeable. Because somebody who's looks a little disheveled, looks a little dirty, you're not exactly comfortable.
Sure.
Understandably, you're a little leery of that. And it really changed how they engage that population. And I'm housed by and by. You didn't ask this question, but one of my owners is a CMHC. I'm living in a mental health first aid, a mental health center. So we are in a CMHC on their first floor.
Yeah.
So we have these people unhoused around us all the time. It can really change your empathy button a little bit once you see this happening.
Yeah, I mean, we have talked a lot about, especially as things have evolved, but people have to, if you're in an assisted living center and you find somebody in the hallway down on the ground, you now have to make an assessment of, is this a diabetic problem? Is this an overdose problem? Is this, there could be any number. Is it an alcohol problem? Like, there's all kinds of things that it might be. You can't just assume where you are. Oh, well, they're let's give them an injection of, we think they're overdosing. So we're just going to give them, like, you now have to make some assessments of people. You might encounter somebody that's got some level of dementia and they may appear inebriated. Like, you have to start to make those differentiations when you're dealing with patients that are complex like this. And I think that's the fact that you provide that education is awesome. Well, this has been awesome. It's been great.
Yeah.
I would say send us that link from that RX Insider. We'll put that, embed that into the podcast. Certainly a link on your pharmacy and what it does. We want to put that out there, and we're happy to have you educate our members, talk about what you're doing, and be involved in ASCP. I think it's awesome.
Thanks. I'm happy to do so. I'm meeting with Jim, Costa, who's silently on mute here for this conversation. I'm meeting with Jim shortly, I hope in the next week or so, because I think though Rhode Island is a small state, we sort of walk around with a big stick in some regards. We do well on the federal level, and I'd really like to be able to begin to educate, our legislative body about some of the interesting, what is it, HR 5034, that law that's out there right now that may give us for a couple of years, those additional dispensing dollars.
Yep.
Yeah, I mean, who knows if it'll happen, but when it comes to an organization like ours, it's a twofer. That's social enterprise. We're like a true double bottom line. Not only are we going to do well by giving people good packaged medication, make them healthy, but everything that this organization does, everything, after it's all said and done, we're helping more than 1,000 people do that. And imagine what I could do if another $30 per each dispense, and I'm doing 150,000 of those a year. If I was able to do that, imagine how many more people I could help with this agency.
Yeah, I think we're pretty bullish. It may not happen quickly, but as we go through all these drug pricing, all kinds of, whether it's most favored nation, whether it's Mark Cuban cost plus, Trump RX, IRA, all these things that are just hammering down on drug pricing, it is, I think, creating an understanding that the pharmacies that do the work have to get paid for the services they're providing.
Absolutely.
You forced us into a world where a lot of that margin from those expensive meds paid for those services, and now you're taking it away, which we're fine with, but you got to pay us for what we were doing. Like, you got to come up with a better way of paying. So I think that's going to happen. Like I said, it might take a little while, might be piecemeal, but I think there's a general recognition that, we can't not pay for the kinds of services you're providing. Otherwise, to your point, 1,000 people won't have access to good medication management. People will end up in the hospital. They won't be adherent, and outcomes will deteriorate. And we have to be able to support the good things that we're doing. So,
absolutely. And Horizon Pharmacy wants to be part of that.
Yep.
So
absolutely.
We are happy to play our part. Can't wait to talk to Jim about it. And I'm deeply appreciated to you two both for giving me a platform and an opportunity to tell you about our story. We're very proud of it, and happy to do the good work in the world.
Well, no, we thank you for what you're doing. All these tidbits, all these pharmacies, all the data that you shared, like, that becomes important when you're trying to talk to a legislator or somebody in the administration, to be able to point to something and say, look, this is what they're doing, and these are the outcomes they're getting. That's critical in our work. So we appreciate you.
Yeah, that's the reason why being an accountant's a good thing, because they could just throw me the claims data and I can make a pivot table out of anything.
There you go. Perfect. Well, any last words, Tom?
Yeah, Jason, I really appreciate your guys' holistic viewpoints, and it's not transactional, just dispensing meds. And the way you guys are approaching this, I think every pharmacy needs to take notice. So I appreciate that. I'm looking forward to the master class. I think you can create your own master class on this that we can publicize. And then lastly, we talk about football a lot, and being from Massachusetts, I'm assuming you're a Patriot fan.
You can take the boy out of Boston. You cannot take Boston out of the boy.
Yeah. So my only question for you is, we know that the Patriots cheated on all the other Super Bowls. How did they cheat this time to make it to this Super Bowl? That's the one question I think everyone wants
Jason,
to know.
he's a Steeler fan. He can't help himself.
We're just looking for their new creative ways of cheating. I'm sure they've got. I'm sure they can teach their own masterclass. But
No, see, I'm a very, very long and old Patriots fan. I'll give you two examples for why. Number one, I was very young when Doug Flutie hit it, and I thought he was going to be the world's greatest thing. I made my dad buy me an adult Doug Flutie shirt at the time. Can you imagine that? It was like wearing a drape over me. I was so into it. And as far as I'm concerned, as long as the Jets have a losing season, the Patriots are doing marvelous. So those are my two benchmarks. If we make it to the Super Bowl, great. But as long as we outdid the Jets, Jason's happy.
That's a low bar right there. So you probably
it wasn't always that way. That's to tell you how long of a fan I can be, man.
That's right.
My dad was a Navyman, and he had a couple of guys that were from New York that would come and watch the games in Foxborough, and they would rib me. I was 9 years old, and they were still ribbing me. So I say down with the Jets. And hey, if the Patriots do well this thing, great. They're already doing better than I thought they would be this year. And if they lose, it's still just a game.
Yeah. Well, that's awesome. Well, thanks again, Jason, for being on, and we'll get those links up. And thanks for being part of this. We'll see everybody next time on the next episode of Rxperience. Thanks, everybody.